and welcome to all today's class on cardiovascular system question answer session. Then we have several questions today, and I want to give the appropriate answers of these questions with some discussions also. Why this is the most correct answers of this scenario actually. And there are several scenarios of a cardiovascular system, and we'll go one after another. So let us start today. The first question is now a 72 years old man who has a history of ischemic heart disease and left ventricular dysfunction is admitted with dyspnea. So this patient has got ischemic heart disease and left ventricular dysfunction. Now this patient is admitted with dyspnea, that is shortness of breath. He has now taken his diuretics for 3 days as he ran out. যেহেতু ওষুধ শেষ হয়ে গেছে এজন্য গত 3 দিন ধরে সে ওষুধ খাচ্ছে না. On examination, you note bilateral crackles to the mid-joints, a respiratory rate of 30 per minute. That is, now he has rapid breathing, and also the man has got bilateral crepes, and that crepes is up to the mid-joints, so the patient should have severe shortness of breath. Which of the clinical finding is most specific with this presentation? This bisphareans pulse, white pulse pressure, warm peripheries, pulses alternance, and forward sound. So among these 5 answers here, so which one is best fit for this case scenario, as this case scenario is suggestive of features of left ventricular failure. So of the 5 answers here, which one is best fit for the scenario of the left ventricular failure? So patient fourth heart sound, actually patient should have third heart sound. Pulses alternance, yes, pulses alternance usually present in a patient with left ventricular failure. Here is usually alternate of the pulse, that is low volume and high volume pulse usually seen. Next we'll see what is the pulses alternance. One peripheries, actually this is not seen. One peripheries usually seen in a patient with cardiogenic shock, shock due to infective cause by septic shock. That is septic shock usually we see this form peripheries. Otherwise, as there is a reduced perfusion to the peripheries due to low output, so there will be low output syndrome, and this patient should have cold peripheries. This white pulse pressure, actually these are features of aortic regurgitation actually, and bisphareans pulse is not a feature of the left ventricular failure also. So if we see the pulses alternance, here you see that there is a alternation of the low volume and high volume pulse, and this is the features of the actually left ventricular failure, and it may be seen following the PVC also. There's a premature ventricular complex, it may be seen, and there may be some other causes also, like typhoid fever. In case of dehydration, we may get this type of pulse. If patient suffering from dilated cardiomyopathy, or if patient is suffering from cardiac tamponade, and we can get this type of pulses alternance in this in the above mentioned scenario cases also, like typhoid fever, dehydration, dilated cardiomyopathy, and cardiac tamponade. So pulses alternance is the right answer in the above case scenario. That is the patient having left ventricular failure, and above the 5 answers here mentioned. So pulse alternance, that is the best answer that fit to the above scenario. So now we shift to the next scenario. A 50-year-old woman with diabetes who smokes presents with jaw pain, severe nausea, autonomic arousal and vomiting, and ECG is performed in the emergency department and shows the anterior segment elevation. Which of the best immediate reference studies here? we see that a patient suffering from ischemic heart disease, they suggest acute coronary syndrome, and acute coronary syndrome, that is anterior ST segment elevation. So when a patient presents with anterior ST segment elevation, so what is the best immediate reperfusion strategy? That as there is a complete obstruction of the coronary arteries due to thrombus, that leads to the development of the anterior ST segment elevation. So there must be some reperfusion strategy. Otherwise, the cardiac muscle will be damaged heavily. So we have to have reperfusion, that is the clot should be lysed and or removed, and we have to have a reperfusion. That is, there are some reperfusion strategy like coronary bypass graft surgery, morphine. Actually, this doesn't have any role in the reperfusion. Its only role is to relieve the chest pain. Parkinson's coronary intervention, yes, that is the one of the most popular as well as effective way of perfusion strategy. Steatokinase, this yes, it is also an effective reperfusion strategy, and tissue plasminogen activator, and this is actually one of the thrombolytics also. So in between, among the 5 answers here, as a patient has got anterior ST segment elevation, so actually this is the best way, that is the most effective way of reperfusion is the primary PCI. When patient admitted into the hospital with ST segment elevation, usually when there is cath lab available and PCI is available, so this patient is sent to the cath lab and angiogram is done, and so and reperfusion also done by either there is thrombosuction as well as there is a stenting or there is a actually removing the clot or thrombus. So this is the primary PCI. So primary PCI is the most effective way of reperfusion therapy actually, and other ways steatokinase or tissue plasmin activator that are actually doing well, but not to the same as effective as primary PCI. So primary PCI is the appropriate answer here. So C, this primary PCI, primary Parkinson's coronary intervention, is the appropriate answer to this scenario. Now we shift to the another answer here. That is a 81-year-old non-smoker presents with chest pain and ECG shows with ST segment depression. His troponin I concentration is 456 nanogram, and the reference size is less than 34 nanogram per liter. He is treated with an angioplasty and stents 2 days later. At the same time, a 60-year-old smoker with diabetes has a large ST segment elevation, myocardial infarction, has ventricular fibrillation in the ambulance, has immediate defibrillation. So his ventricular defibrillation was treated with the defibrillator or DC cardioversion. He undergoes immediate PCI on arrival at hospital and has a troponin concentration of more than 50,000 nanogram per liter. It indicates that there is a severe damage of the cardiac muscle. So this troponin I actually or troponin T concentration usually coincides with the degree of cardiac muscle injury. So more cardiac troponin I level, more actually the troponin I level. So there will be more that is troponin I that indicates there is a more cardiac muscle injury. So when there is a more cardiac muscle injury, there is more chance to develop different types of complication like pump failure. There is a more chance of develop left ventricular failure. There is a more chance of develop actually the ventricular fibrillation or any type of arrhythmia, like the patient, second patient that have, and he was treated with defibrillation. So actually, the more the troponin I, so more that is the more bad prognosis actually. So more worse prognosis of this patient should have. So what is the biggest predictor of mortality following acute myocardial infarction? So as that the important predictor or ECG changes. That is also if there is more ECG lead changes, there is more ECG ST elevation in the more leads, that indicates the more cardiac mass involvement. And so that has worst prognosis also. Smoking also is an important factor, but not so much important factor like troponin I or other ECG changes and troponin concentration. Yes, this is the actually the most important predictor or the biggest predictor of mortality following the acute myocardial infarction. If a patient has more troponin I or large amount of troponin I, that indicates this patient may have bad prognosis like pump failure or any other of complications may arise later on. So we should be cautious about the patients. Even we should have the cautious regarding the counseling of the patient's party also. So I think this is the E is the most appropriate answer here, troponin concentration. Though some other answers contribute to a small to a large, but troponin concentration is the biggest predictor of mortality here. This is another question. A 60-year-old man who is investigated for exertional chest pain is diagnosed as having angina pectoris. So this patient is 60 years old, having exertional chest pain, and his diagnostic of the chest pain is a diagnostic of angina pectoris. Which of the following drugs is most likely to improve the long-term prognosis? So atenolol has got actually some prognosis. Aspirin also some positive prognosis that reduces the mortality. Atenolol also causes some mortality, but in comparison to metoprolol, metoprolol is more effective in terms of long-term prognosis or to reduce the mortality than atenolol also. Isosorbide monohydrate, actually isosorbide monohydrate is more effective to relieve the pain, but it has little role in improving the long-term prognosis. That is little role to reduce the mortality also or morbidity. Ramipril, yes, Ramipril is the by HOPE trial. It shows that Ramipril actually has the biggest role in the improving the long-term prognosis, as well as the to reduce the long-term mortality, as well as the long-term morbidity also. So, and nicorandil actually it is very much a small role to have the to reduce the long-term prognosis, that is long-term mortality and morbidity. Like nicorandil action is like isosorbide monohydrate-like action. So nicorandil, isosorbide monohydrate has little role. Atenolol, aspirin has got some role, but ramipril has the biggest role to reduce the cardiovascular mortality and morbidity. So it is an important role to reduce the cardiovascular mortality and morbidity in the long-term prognosis. So ramipril is the answer here, and here HOPE study suggests this role of ramipril to reduce the mortality. Millimeter mercury. So there is a severe hypertension. It's referred for so sorry for the interruption actually. So we are in the here. So sorry for the interruption. So we should continue. We should continue. There is what is the commonest cause of secondary hypertension? There are 5 answers given here. Congenital adrenal hyperplasia, Cone syndrome, pheochromocytoma, renal disease, and thyrotoxicosis. These are the 5 answers to be given of the cause of the secondary hypertension. But among these 5 answers given here, actually renal disease is the common cause of secondary hypertension. We usually found this chronic renal failure or any a type of renal disease that can lead to the development of the secondary hypertension here. So, renal disease is congenital adrenal hyperplasia, Cone syndrome, they are very much rare. Pheochromocytoma also rare. Thyrotoxicosis is a little bit not so common, but renal disease is actually so common cause of the secondary hypertension. So, D is the appropriate answer here. So now we move to the another answer, another scenario. A 60-year-old man is referred by his family physician because despite 4 drugs, he continues to have uncontrolled blood pressure. So this patient is getting 4 drugs to control his hypertension, but in spite of getting 4 drugs, his blood pressure is not controlled enough. So the doctor feels that the patient needs further investigation for a potential secondary cause of hypertension. So it is another question regarding the secondary cause of hypertension. What is the commonest cause of poorly controlled hypertension? So in the common practice, in our practice, we see there is some common cause of poorly controlled hypertension. So, there are 5 questions here. That is Cone syndrome, glucocorticoid suppressible hyperaldosteronism, hyperenemia, poor adherence with medication, and renal failure. So, though we can encounter there are several common causes of secondary hypertension with renal failure, but the poor adherence with medication, that is the most common cause of actually poorly controlled hypertension. If patient is now there is poor adherence, or that is a patient not getting antihypertensive properly prescribed, but patient not getting properly, so his blood pressure will not get properly controlled. As we know that hypertension is a silent killer disease, and most of the cases in patients suffering from hypertension may don't have any symptoms. For this reason, the patient usually not getting or taking antihypertensive properly, and so their actually hypertension remain uncontrolled in the most of the cases. So this is the one of the cause of being uncontrolled hypertension, and so poorly adherence to the medication is the important cause of being uncontrolled hypertension. So poor adherence with medication, so this should be the answer here, poorly controlled hypertension. So now next question is an 18-year-old woman presents with a sore throat and suspected acute rheumatic fever. Which of the following is a minor manifestation of acute rheumatic fever? So carditis, if we recall, already we have discussed in the some class back that we discussed about the rheumatic fever in details. If we recall the major manifestations of the rheumatic fever like carditis, arthritis, Sydenham scoria, that is erythema marginatum. So these are the actually and saphenous nodule. These are the 5 important manifestations. So that's a major criteria of the rheumatic fever. So there is carditis is actually this is the major criteria. Sydenham scoria also is a major criteria. Erythema marginatum is also a major criteria. And rare C-reactive protein, actually this is a minor criteria. So among these 4 answers, D is the correct answer here. There is rare C-reactive protein is a minor criteria, and carditis, Sydenham scoria, erythema marginatum, arthritis, there is a fleeting arthritis, large joint arthritis, or migrating polyarthritis actually. and subcutaneous nodule. These are the 5 actually major criteria, and there are several minor criteria. Among them, raised CV reactive protein is a minor manifestation of acute rheumatoid fever. So the answer is here D, that is raised CV reactive protein. So now we can shift to the next answer here. Next scenario, you are an SHO working at District General Hospital in some place. A 56-year-old man presents to the emergency department with crashing central chest pain that started 30 minutes ago. He is demonstrated ST elevation in the anterior leads. He is treated for an ST elevation MI. So this patient suffering from ST elevated MI. So far, he has been given aspirin, clopidogrel, low molecular heparin, and his chest pain has significantly improved with sublingual GTN and IV morphine and metoclopramide. So his pain is subsided, but this patient actually suffering from ST elevated MI. There is no cath lab on site, that the hospital don't have any cath lab facilities. And the nearest Parkinson's coronary intervention center in Truro is approximately 2.5 hours away. Which of the following is the most appropriate course of action now should be taken? There is transfer to the PCI center. They give her bivalirudin, start infusion of unfractured heparin and transfer to PCI center. Actually, patient already given low molecular heparin and his pain is already subsided. Given alteplase, that is thrombolytics, or give it glarol, that is antiplatelet drug. Already patient is taking aspirin, clopidogrel, antiplatelet is already given to this patient. So what should be the most appropriate answer here, as this patient having ST elevated MI? And we all know that ST elevated for the treatment of the ST elevated MI, primary PCI is the gold standard treatment now. And if primary PCI is not available in a center, and if the to get the primary PCI facility, if the distance of the hospital where PCI is available is far away from the center, and it takes so much time, in that case, patient should be given thrombolytics. As the patient is suffering from ST elevated MI and primary PCI is the gold standard treatment, so the next center of the PCI is not so far away from the center. There is only 2.5 hours away. So this patient actually should be transferred to the next PCI center to have the primary PCI actually. So transfer to the PCI center, that is A is the appropriate answer here. And this patient actually should get the primary PCI, and this patient should be transferred to the PCI center, that is the next PCI, next the center that have the facilities of the primary PCI. So I think transfer to the PCI is should be the most appropriate answer to this scenario. We actually already discussed this scenario in the last class. As there is some sub-questions of this scenario, so that for this reason, actually, we repeat this scenario to discuss the next questions. Actually, a 65-year-old man present with a 4-week history of generalized malaise and lethargy. He has 2 courses of antibiotics that have temporarily improved his symptoms, but he continues to feel worse over time. His family physician notices he has become anemic. He attends the emergency department. He is admitted to hospital with a fever. He has some blood cultures taken. He undergoes an echocardiogram which shows a mass on his mitral valve. That is, the patient is having infective endocarditis. So what is the most likely organism that will be grown from this blood culture? We already discussed that Staphylococcus aureus, Staphylococcus epidermis, Streptococcus faecalis, Streptococcus galolyticus, and Venus streptococci. We already discussed that the Streptococcus venus is the most common organism to have the infective, to cause the infective endocarditis. So we the next questions we already discussed these questions scenario and answers. So I already discussed this thing. This questions is not discussed in the last class. So considering the patient, the last question, that is the patient having the infective endocarditis, blood culture demonstrates virulence streptococci. What is the most appropriate antibiotic regime to commence the patient on? Now, if the patient blood culture grows the streptococcus virulence, so what is the most appropriate antibiotic that the patient should get? Intravenous ampicillin and gentamicin, intravenous benzyl penicillin and gentamicin, intravenous flucloxacillin, intravenous vancomycin and gentamicin, or oral benzyl penicillin. So among these 5 questions, actually it is clear that the patient should get intravenous benzyl penicillin and gentamicin. This patient has got infective endocarditis, so there is no options to have the oral antibiotics here. So this patient should get IV antibiotics. So among the IV antibiotics, as the organism is virulent streptococci, so penicillin is very much sensitive to this organism. So this patient should get intravenous benzyl penicillin and gentamicin combination. So here we see that there is a therapy of infective endocarditis. This patient having the streptococcus, the patient should get benzyl penicillin and gentamicin combination. If patient is allergic to penicillin, that instead of penicillin, this patient should get vancomycin along with gentamicin. And if the organism is Staphylococcus, so there should be beta-lactam resistant penicillin, flucloxacillin as some other drugs that is resistant to the beta-lactamase, and gentamicin should be added to this drug also. And if patient is allergic to penicillin, that in case of Staphylococcus, that is beta-lactam resistant penicillin, so in that cases, patient should get vancomycin along with combination with gentamicin also. So actually, this is the regime to be given to a patient suffering from infective endocarditis, depending on the organism that is found on the blood cultures of the patient. If the patients have Streptococcus virulence, those in that cases, patient should get penicillin and gentamicin. If the patient culture shows the Staphylococcus epidermis or aureus, then patient should get beta-lactase resistant penicillin along with gentamicin. And so, and if patient is allergic to penicillin, so in case of penicillin, this patient should get vancomycin. So this is the actually principle of treatment to a patient having infective endocarditis. So these are also some key recommendations for practice if a patient having infective endocarditis. This is also the treatment options of a patient having infective endocarditis, depending on the organism that is actually found on blood culture. So this is another case scenario here. A 30-year-old woman is admitted to the emergency department following the acute onset of palpitations. So this patient is suffering from palpitations, and this is a young lady having 30 years old. Blood pressure is 124/84 millimeter mercury. That is, patient is monotonically stable. Our pulse is 150 beats per minute, and ECG shows a narrow complex tachycardia. So maybe as the patient is suffering from narrow complex tachycardia. So the commonest cause of narrow complex tachycardia is actually supraventricular tachycardia. So intravenous access is gained and 6 milligram adenosine is given with no effect. As the patient is suffering from narrow complex tachycardia, that suggestive of infective endocarditis, that's suggestive of supraventricular tachycardia. So this patient is treated with adenosine IVs, that is 6 milligram was given. What is the most appropriate next step actually should be given? So there are 5 options given in that is intravenous adenosine 12 milligram, that is the double dose of the adenosine. Intravenous adenosine 6 milligram, that is the same dose that is repeated. Intravenous verapamil 2.5 milligram, that is instead of giving adenosine, the drug is changed, intravenous verapamil is given. Radiofrequency ablation was done, and electrical cardioversion as the patient is suffering from SVT and the patient pneumonia is stable. So actually there is a little load of the electrical cardioversion. If the patient was pneumonically unstable, then in that case actually DC cardioversion should be given immediately. and that is the actually best option or the appropriate option if a patient having supraventricular tachycardia with hemodynamic and unstable. But radiofrequency ablation actually not should be given at this time. Actually, after a stable of the patient, actually we shifted to the patient with in the cath lab, and in that cases, EP study was done, then the radiofrequency ablation was done. So that is a long procedure to get the radiofrequency ablation. So it is not the immediate treatment actually. Intravenous verapamil, that is the answer. But if adenosine is failed, first dose of adenosine is failed, that what is the next option actually? Here we see that there is regular SVT. If a patient come with supraventricular tachycardia or narrow complex tachycardia, such of supraventricular tachycardia, patient should get vagal maneuvers at first. If his hemodynamic is stable, and or IV adenosine should be given. If not effective or not feasible, still patient is hemodynamically stable, then IV beta blockers, IV liltiazem, IV verapamil should be given. And if patient is not hemodynamically stable, then synchronized cardioversion should be given. And if beta blockers, liltiazem, verapamil, and all these drugs failed, actually in that cases, DC cardioversion should be given. And this actually shows another mode of treatment of patient have irregular SVT. Actually, this is the flow chart of treatment of the regular SVT. And if we see the this slide actually, if the patient has got SVT and is a vagal maneuver, then adenosine. At first, we give adenosine. If adenosine is not effective, actually after 2 minutes, the dose is doubled, should be doubled. And if not effective, then actually the dose further actually increased. So the dose it should be doubled if first dose is missed or first dose is actually failed. So this should be the answer here, intravenous adenosine, as in the first attempt, IV adenosine 6 milligram was given. So and this first attempt has failed. So intravenous adenosine 12 milligram should be given for the second attempt. So IV adenosine 12 milligram, that is double the dose, should be given. So this is the answer here. So we shift to the another scenario. The army recruit is referred for assessment because there is a family history of sudden cardiac death. An uncle was diagnosed with hypertrophic cardiomyopathy. In which manner is hypertrophic cardiomyopathy commonly inherited? So, as hypertrophic cardiomyopathy is a genetically transmitted disease. So, how it is transmitted? It is an autosomal dominant, it is an autosomal recessive, it is not inherited, X-linked dominant or the X-linked recessive. So actually what is the, how the actually this disease is transmitted vertically. So hypertrophic cardiomyopathy, as there is a family history of sudden cardiac death, and his uncle was diagnosed with hypertrophic cardiomyopathy. And actually, this is the autosomal dominant disease. And now we have to have some discussion about the hypertrophic cardiomyopathy, that is autosomal dominant disease caused by mutations in one of the 11 cardiac sarcomere or adjacent disc gene. Actually, there is actually a lot of mutations of the genes. Actually, there is a structural protein change actually. And there is a genetics about approximately 50% of the patients have mutations in one of the more genes. Diagnosis is done by there is increased LV wall thickness, and this LV wall thickness is detected by the echocardiography or MRI or nuclear imaging or computed tomography or genetic screening. This hypertrophic cardiomyopathy, that is increased LV wall thickness, can be detected, and the pathophysiology is like increased LV wall thickness without abnormal loading conditions. Usually, we know that when there is a valvular heart disease, especially outflow tract obstruction, especially aortic stenosis, aortic agitation, or there is a systemic hypertension, so when there is a load over the left ventricle or right ventricle, so there may be hypertrophy to overcome the load. But if without any overload, if there is a hypertrophy, and then maybe asymmetrical hypertrophy, not concentric hypertrophy, and this hypertrophy usually occurs in the most cases there is a septum, but this hypertrophy may occur asymmetrically. That is, the hypertrophy may occur only in the apical part, only in the outflow tract near the septum, that is basal septum or mid septum or apical septum, or it may actually involve any part of the left ventricle or right ventricle. Well, that may lead to the development of the asymmetrical hypertrophy of the left ventricle, and it causes the it's the features of actually hypertrophic cardiomyopathy. So that may lead to the development of the interstitial fibrosis, and this interstitial fibrosis always is a precursor of developing arrhythmia actually, and this is the nidus of developing arrhythmia. So there may be also cardiomyocyte hypertrophy, and there may be this array of the cardiac myocytes arrangement also. So actually, this is the pathology and pathophysiology of the patient having hypertrophic cardiomyopathy. So actually, so how the hypertrophic cardiomyopathy is usually inherited. Actually, it is an autosomal dominant disease. So autosomal dominant, that is the answer A, autosomal dominant is the correct answer here. Now we move to the next questions. A 30-year-old male has progressive exertional dyspnea due to progressive systolic heart failure with a left ventricular ejection fraction of 30%. That is, the patient has actually severe left ventricular failure. Heart investigation most useful in predicting symptomatic response to cardiac resynchronization therapy. We all know that if a patient suffering from severe LV systolic dysfunction, and in that cases, if patient is not responding drugs enough, in that cases, usually recommend the cardiac resynchronization therapy, that is CRT. And following the CRT, there are several investigations that is used to follow up the patients. Either the patient is improving, either in the form of ejection fraction, or either in the form of to reduce the actually biomarkers of the left ventricular failure like BNP level or even troponin level, or there may be improvement of the ejection fraction, as well as there is a size of the left ventricle improvement. So we measure actually this in different investigational procedures like echocardiography and cardiac MRI. So cardiac MRI and transesophageal echocardiography actually not transthoracic echocardiography actually enough to assess a patient having a CRT, that is cardiac resynchronization therapy, and to see the improvement of the patient left ventricular function actually. So transesophageal no transthoracic echo is enough, but cardiac MRI is more effective way to assess the improvement of the left ventricular function actually. So cardiac MRI is the right answer here to see the improvement of the cardiac function of a patient suffering from the left ventricular failure and having the CIT as a treatment option. So cardiac MRI actually this is the most appropriate answer here to assess the left ventricular function of a patient having CRT in a patient with left ventricular very reduced left ventricular fraction, there is severe LV dysfunction. This is the explanation of the answer here actually. This is the echocardiography and CRT. This is the answer here. So now we can move to the next case scenario actually. A patient presents with an incidental finding of a mass in the left atrium who is undergoing an echocardiography for hypertension. What is the most likely cardiac tumors in this situation? a patient suffering from hypertension is being done echocardiogram to assess the actually different function and to find out the different tension or impact of hypertension on the heart also. But incidentally, it is found that the patient has got a cardiac tumor, actually, especially in the left atrium. So, what are the actually most common causes of the mass in the left atrium, actually, or tumor in the left atrium? So, angiosarcoma, atrial myxoma, fibrillostoma, fibroma, lipoma. These are all type of actually tumor that can affect the heart, but left atrial myxoma is the commonest cause of tumor arising in the left atrium. So atrial myxoma, that is B, is the appropriate answer here. So here in the slide, we see that the most common benign cardiac tumor is a myxoma, and myxoma are generally found in the left atrium arising from the stalk attached to the fossa ovalis membrane. The most common primary cardiac tumors in children are the rhabdomyoma and fibroma, both of which are benign. So myxoma is the commonest tumor arising in the left atrium. So here B, atrial myxoma is the answer. If we have next questions, I think it is maybe the last questions today, last scenario. A 43-year-old man has an extensive antimicrobial infarction, has received antiplatelet, anticoagulant, statin therapy. A patient around 43 years having extensive antimicrobial infarction, and he was given the standard treatment like antiplatelets, anticoagulants, and statin therapy. He is referred for an echocardiogram. What will transverse echocardiography most useful assess in this setting? So actually, what the things actually we see if a patient have a myocardial infarction, especially by the echocardiogram. So when we do echocardiogram following a patient, following a myocardial infarction of a patient, that is a patient suffering from MI, what features actually we usually find, or what things usually we assess? This cardiac arrhythmia, this future prognosis, left ventricular function, and the presence of mural thrombus, myocardial scar formation, thrombus in the left atrium. Actually, when a patient having left ventricular, that is a myocardial infarction, actually during echocardiography, we commonly see the left ventricular function actually, as well as if there is a myocardial infarction, there is a damage of the wall of the heart, and that may lead to the development of the reduced movement of that part. That can lead to the development of the thrombus. So there may be mural thrombus if there is a reduced ejection fraction of the left ventricle, as well as there is a reduced movement of any part of the left ventricle in the free wall or the septal wall. And there may be aneurysm formation also. And this aneurysm formation usually this wall or this part is dyskinetic or akinetic or hypokinetic. These actually leads to the development of the formation of the left ventricular or mural thrombus. So usually we look for following myocardial infarction, usually we look for any thrombus within the left ventricle, as well as the function of the left ventricle also. And also the actually the movement of the left ventricular wall, we usually see the patient having the myocardial infarction. So among these 5 answers, see that that is left ventricular function and the presence of mural thrombus. This is the appropriate answer here, I think. So I think we can stop here today. So good night. Stay safe, stay blessed. Thank you all for patient sharing.